note today's session is being recorded. If you have any objections, you may disconnect at this time. Thank you very much. On behalf of the National Cancer Institute, I wish to welcome everyone to today's session. We are excited to be joined by our speakers, but before we get started, a brief word about logistics. All lines are in listen-only mode. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded, and muting all lines will help us to avoid any background noise. If you are needing to view live captioning, please refer to the link that will appear in the chat box or that was sent in the reminder email for today's session. We encourage questions and comments. Questions can be submitted using the Q&A feature on the right-hand side of your screen. Please type your question into the provided Q&A field and hit submit. Feel free to submit your questions at any time during today's call. We will be using the chat panel to share resources throughout today's talk. Note, you may need to activate the appropriate panel using menu options found at the bottom of your screen. Lastly, we recommend navigating to the View menu at the top of your screen and selecting Hide Non-Video Participants, as this will give you the best glimpse of our great speakers. And with that, I will turn it over to David.
Well, thank you, Sarah, and thanks so much to everybody for joining us. We are excited to once again be doing our fireside chats where we welcome our experts from around the country and at times beyond that to help us really talk about issues of importance to the implementation science community. And often we know that the field is multidisciplinary, transdisciplinary, lots of disciplines represented, but we don't always think through the best ways to harness the wonderful expertise, the experience, all of the work that's going on in some of these fields. And so we thought that it would be helpful to have a number of conversations where we really thought about those sorts of intersections among our broadest scientific and as well as practice and policy communities. And so everyone may have your own Venn diagram in your mind about how some of these different fields come together. And of course, what we're hoping to accomplish over this hour is to walk through what that Venn diagram can be, how can we expand at least the intersection points. And so we're starting out with thinking about implementation science and epidemiology, and we're so grateful to have Anna and Daniel here with us. Anna Diaz-Rue, the Dean and Distinguished University Professor of Epidemiology at Drexel, and Daniel Westreich, who is a full professor of epidemiology at UNC Chapel Hill, to really help us think through addressing your questions, your thoughts, and really think about how through their career and what they see of these fields going forward, what can we do together, and how do we make the most of all of the expertise that we have around us. So first off, just want to welcome Anna and Daniel. Thanks so much for being with us.
Thank you for having us.
Great. And so I wanted to just see if we could start out by probing a little bit into what we think of as your superhero origin stories, but telling us from the perspective of epidemiology, how did each of you first become interested in epidemiology and what you focused on in your research? You'll see in front of you, and periodically you'll see various lovely pictures of the fire, all open access. So that's just a way of trying to create this hopefully warm and lovely conversation that will not only involve the three of us, but all of you who have questions out there. So Anna, do you want to kick us off with your sort of origin story in terms of epi, and then Daniel, you want to follow?
Sure. So first, thanks for having me. I think this is a really interesting conversation to have, and I'm delighted to be here with you and Daniel. So I got into epidemiology from medicine. I was working as a pediatrician in Argentina, where I'm from and where I trained as a pediatrician, working in a big children's hospital, but also rotating through health centers in the sort of the outskirts of the city, and really realizing that there was this whole world out there that affected the health of the kids that I was seeing that I could not get at through medical care. So this interest in populations and also in action, right? Which I think these are things that connect to implementation science very well. So that's, I became intrigued by this idea that there was a whole science out there, which was about population and how diseases pattern in population and what things we can do to affect those patterns. And so that's how I really got interested in epidemiology. And of course, initially, people have preconceptions about epidemiology. In my hospital, it was only about controlling infectious transmission in the hospital. That was really it. But actually, as we know, it's much, much broader and very interdisciplinary. So that's kind of how I came to it.
Awesome. Daniel, you want to join?
Yeah, and thank you for having me. And Dr. Diaz-Rue and I came from very different directions in that I was in my undergraduate, I studied computer science and was living in Seattle and working in software engineering for several years after college, but started to feel like I wanted to work in something with more immediate social value. I like to joke that I was working at Microsoft at the time, and I think I beat Bill Gates to the global health beat by at least a couple of years. I don't think I had anything to do with that, but through social groups that I was a part of and friends, I was introduced to global public health and started to figure out that that would be a place where I could do the kind of impactful work that I thought was valuable in the world while not letting go of some of the quantitative and logic-y skills that I had developed as a computer scientist and software engineer. And sort of moved towards public health from there, eventually finding my way to epidemiology. And this has led to a lot of the ways that I view epidemiology, in that I view epidemiology as much as an engineering discipline as I do a scientific one. And I think that's going to be a theme that's going to emerge as I talk a little bit more about implementation science, which often is not as really implementation engineering, in my opinion.
So thanks for also providing a wonderful segue, because I think the next thing that we wanted to ask of each of you is that initial introduction to implementation science. How did that come about? How did you first become introduced to it? And how did you decide that it was something that you might want to at least focus more on to different extents over the years afterwards? Daniel, do you want to start us off as that segue, and then we'll go to Anna?
Sure. Well, so I would clarify a little bit that I don't think that I do implementation science. I think that what I do is epidemiologic methods for implementation science. And I'll explain a little bit what I mean, but the way I got here is through epidemiologic methods for causal inference. And there are a series of sort of methodological tools that I learned through my postdoc and with collaborators like Steve Cole at UNC and some others, that as I learned them taught me to think differently about problems and to think differently about the questions that we are asking. And as I started to think more and more about the questions we're asking, I started to realize that the questions that I was asking often didn't make a lot of sense. And so my real revelation about this came when I was studying the intersection of HIV and women's reproductive health in a data set in South Africa out of the Tembeleti Clinic in Johannesburg, where I was asking a question about what the impact of pregnancy was on response to antiretroviral therapy. And the sort of traditional epidemiologic approach to this winds up in the statistics asking a question which amounts to the same sort of question you'd ask in a trial. Namely, what if all the women here had been pregnant? What kinds of outcomes would we have seen? What if none of these women had been pregnant? What kinds of outcomes would we see? How do those two things compare? And under various identification conditions, we can interpret that as a kind of causal effect, et cetera, et cetera. I don't need to get into the methods deep into the weeds right now. But as I was trying to answer this question, it occurred to me that those two exposure conditions, what if of the 6,000 women I was studying, what if all of them had experienced a pregnancy, was not a very sensible thing to ask, nor was it very sensible to ask what if none of them had experienced a pregnancy, because there are no universes in which those two exposure conditions makes very much sense, right? If it turns out, in fact, that pregnancy impacts response to antiretroviral therapy, maybe that's a thing that you would want to communicate to women, and maybe that would be a reason that certain women would be more prone to taking up contraceptive technologies if they were available. but there's no universe in which all of these women would become pregnant. In fact, only about 10% of them did during the study period. And there's no universe in which none of them would become pregnant. And so that contrast in counterfactual exposure conditions doesn't have any real relevance to any policy you can ever imagine implementing among a population of women, some of whom actively want to become pregnant and bear children, and others of whom actively don't want to become pregnant and might want contraceptives if those contraceptives were more available. And so the thing that I noticed was that disconnect between the question that the method leads you to ask by default and the questions that are actually relevant to policy. And the questions that are relevant to policy are things like, well, some of those women's pregnancies were maybe unintended, and maybe some of those women might have wanted to prevent those pregnancies if we had offered them contraception at some point in the course of getting antiretroviral therapy. And so what would happen in that counterfactual? What would happen if we had offered them some kind of intervention that they might optionally take up if they desired? That's a question that is relevant to an actual policy that you could ethically imagine offering to real people in the real world. And it is so many steps from the thing that epidemiologic methods tend to answer by default and without examination that really struck me and led me down the road of, well, so how do we ask better questions? What better questions can we ask that provide evidence that's a lot closer to policy decisions than the sorts of answers to the sorts of questions we ask by default?
Gotcha. So shifting from the maybe this is of interest intellectually versus is this a question that we need to answer to try and have some tangible impact on practice and policy?
Yeah, I think of this as the sort of road from science to policy or from exposure, like asking questions about the effects of exposures, like pregnancy, to asking about the effects of potential interventions, like offering contraceptives to people who want them.
Sure.
Okay? And we tend to conflate those two things often when we talk about epidemiologic methods, and I find a lot of value in trying to separate them out.
Gotcha. Anna, same question for you. How you sort of first got started thinking about implementation science?
Yeah. So I think, well, there are many different definitions of implementation science, right? I'm sure that everyone on this call might have a slightly different variant. I first kind of became in contact with the whole concept of implementation science, I think, probably when I met you, David, at a meeting. We were remembering a number of years ago now, and I think you said something like, "Oh, this is really interesting and relevant to implementation science." And I was like, "Well, I don't know anything about implementation science." And over time, as I sort of learned more, I realized that there are so many connections between epidemiology and implementation science. And to me, I think implementation science, I'll give you my version, is about, I guess two big buckets, sort of what works and what doesn't, in whom and under what conditions kind of thing. And then why are we not implementing what we know works, right? So those questions, I think, the work that I've done as an epidemiologist are, perhaps not super specific to each of those things, but they are highly relevant. And so I've seen, the more I've been in contact with folks who do implementation science, the more I see connections and possibilities and the value of having these kinds of conversations. I mean, in some ways, picking up on something that Daniel was saying, in thinking about, conceptually, in some ways there's a continuum, right, between broad questions about determinants, I won't even use the term cause, all the way to what works under specific circumstances and in whom, right? How do causal effects operate under specific circumstances and in whom? And so there's a continuum there. And maybe, some more traditional epidemiology might be towards the broader piece, and implementation science is right at the more specific. But in reality, they're connected. And so I really like to think of it that way. And the methods, of course, the more you get to the more specific, the tighter the causal inference becomes, and, the more well-defined, as Daniel was saying, the intervention is, et cetera, et cetera. But I think the whole continuum is informative as we're thinking about interventions and policies. So that's how, the more I realize that, the more I become more and more interested as an epidemiologist in the whole world of implementation science.
Yeah, thanks for that. Yeah, sorry. Were you, Daniel, jumping in? Oh, sorry. I thought I heard a strange background noise. That just goes with the territory. Gremlin somewhere around. So just wanted to ask maybe a sort of further mining of your thinking about how implementation science, again, recognizing that there's variable definitions, but are there ways in which it informs or has sort of shifted the way you think about particular research questions? Daniel, I think you already talked about maybe one example of fine-tuning the methods around the questions that we need to ask. Maybe Anna, starting with you, just other insights of ways in which it carries through in some of the work that you've been doing.
Well, I think, there are two sort of concepts, or I guess they would be concepts, I think, that are particular relevance that have become more salient to me, I guess, as I think about implementation science research, although I don't claim to be an implementation scientist. There are others who are much more focused on that. And there, one is of course, the whole issue of generalizability and effect modification and conditional effects, right? That, which are basic concepts in epidemiology, but that are highly relevant to implementation science, right? This idea of, how do causes in, how do existing conditions, other constellations of existing conditions modify whether a certain intervention has the anticipated effect or not, right? And so that's, that's one way that, the goal of implementation science has affected the way I think about things. And then the other area which sort of builds on that is the need often to bring in sort of the systems vision, systems approach or conceptualization of the system within which these interventions are acting as a way to also help us understand conditional effects, unanticipated effects, for example, and also, also the tools of systems modeling as a complement to experimentation, evaluation, and observational studies. So this need for a multiplicity of methods, complementary methods, I guess.
Yeah, and it was actually, I remember at that Maternal Child Health Epi conference where I was asked to talk about implementation science, and you were focusing on system science, and I think it was that conversation about shouldn't these two come together more? Mm-hmm. That's right. Daniel, you want to jump in?
Yeah, well, I want to pick up a couple of the points that Anna was just talking about. One is the systems approach. One of the things that this perspective has made me more aware of is how, and I would be really interested to hear your perspective on this as a dean, Anna, how much my epidemiologist, but really in some sense every department within the School of Public Health often is sort of isolated from each other, when in fact, so going back to my earlier example of not just the effects of pregnancy, but maybe the effects of offering Depo-Provera to women arriving for antiretroviral care in South Africa, that is starting to think about what is the intervention, not just from a sort of both what the policy is and what the sort of health behavior aspects are, provides real opportunities for cross-departmental collaborations too. Those are things that I'm not particularly an expert in, right? And there are very clear opportunities there for me to be getting help and building ties with people in health behavior and with health policy to try and get those models done in a really rigorous and sort of turnkey ready sort of way, so that once the modeling is done, we have an answer, maybe it can just go and be done if it's it's a good idea. So that's one thing. And so I think that taking this perspective, which I have referred to previously as a causal impact perspective, moving beyond causal inference to thinking about the causal impact of things. Taking that perspective can provide, I think, real pathways for interdepartmental collaboration within schools of public health in ways that I think are really valuable. The other thing that taking this perspective has really made me think of relates to Anna's point about generalizability. But to take that a step further, it's really made me even more skeptical of the hierarchy of evidence and the hierarchy of study designs, because the hierarchy of study designs is really seems to me increasingly that it is based really on only looking at causal effects within a study sample. And if all you want to do is make inference within a particular study sample and not go outside of that study sample, then I understand everyone's attachment to the hierarchy of study designs. But as soon as you start thinking about issues of quantitative generalizability, as Anna was alluding to, or of the difference between the effects of an exposure like pregnancy to the effects of an intervention like offering Depo-Provera to people, or to take another example, the effect of smoking versus the effects of a smoking cessation intervention, which is not 100% perfect at getting people to quit smoking, right? As soon as you start separating these things out, the distance starts to grow between the quality of evidence internally and what it could mean in some arbitrary target population under some arbitrary implementation scheme. There's a lot of distance there, and the assumption that the randomized trial, which is often the Cadillac intervention, right? You know, it's not necessarily the most realistic, scalable intervention that you could possibly have in a probably highly selected population, because we often enrich our randomized trial populations for people at high risk, maybe with a weird distribution of effect modifiers, as I was alluding to. The idea that that evidence is definitely the best evidence for making a decision in some other population far away that doesn't have anything to do necessarily with your study sample, that becomes more and more questionable. And it turns out that we can interrogate that entire idea quantitatively. And when you do, the thing you find is that the question of the hierarchy of study designs is an empirical question and not a sort of ideological one or theoretical one. It's empirical. It's about how much bias is there. And sometimes there's less bias in the observational study for a particular target population than there is in the weird, highly selected randomized trial for that same target population. And that doesn't mean that we should throw out all of our evidence or not take randomized trial results seriously. Of course, we should take them seriously. But the sort of casual dismissal of observational research is the thing that I want to draw attention to. And that taking this implementation science perspective has really clarified for me the ways in which we do that and the ways in which that can actually lead us really far astray.
Thanks for that, Anna. Any thoughts about that? Yeah. Oh, I think you're on mute, sadly.
I think that's a really great point, Daniel. I was just reflecting on that. I mean, I think, you know, this also connects to the whole systems idea, right? Because if you're trying to understand how a particular intervention will impact something in a system, you need to combine all these different kinds of information because you're trying to understand the whole system, really. And that's what allows you to predict the impact of the intervention in the context of that system. And you can't do that only with a randomized trial, as Daniel was saying, in a super selected population, you know, where you're holding a whole bunch of other things constant, you know. So I totally agree with Daniel that I think we have to think about evidence in a much broader way and not this rigid hierarchy. That doesn't mean accepting less rigorous evidence, not at all. It just means, you know, building the evidence base to really understand how the system works. That's really what you're trying to understand and what allows you to predict understand how an intervention might work or what you might do in the system to make it work better, right? What other levers you have. For example, this comes up a lot in the social determinants of health world. What can you do via policy in people's housing or neighborhoods to improve the impact of diabetes treatment, which you're getting in the clinic? What can you do to support that, to magnify its effect, and I don't think we do, that's a really big issue that we don't really focus enough on, and it's totally an implementation science question, I think.
Yeah, so I'm just scanning both sort of chat, Q&A, and I think a lot of the points that both of you are making are resonating quite significantly among our group. I do want to also make sure that we're starting to pull in the questions that folks are offering to us. So one, I think, really speaks to what you were just saying, and that's whether you have some thoughts or any theories about how best to integrate systems concepts. Is it about mixed methods to include more contextual factors, or what do you see as a way in which we can credibly better focus on what the sort of system level provides? Any thoughts? Maybe Anna, do you want to start there?
Well, I think there are many different ways. I think a starting point is to, whether you're studying a particular intervention or whether you have a more general causal question, broadening your conceptual model to be a dynamic model, right? And to encompass the kinds of things that characterize dynamic systems, like feedback, dependencies. That doesn't mean creating this super complicated thing. You still have to, and that's the job of the scientist, you still have to set bounds on it. You have to make choices about what's important and what you're going to ignore, and someone can disagree with you on that. But starting with a dynamic conceptualization of the problem, and that's often the hardest piece because we're so trained to do the arrows like this, in just one direction. And then, there are complementarity of methods. You can interrogate systems using observational studies. You can interrogate systems using experiments. You can interrogate systems using modeling, simulation modeling. You can interrogate systems using more participatory qualitative approaches, like participatory group model building, for example, that can yield insights. So I think we have to sort of open up ourselves to these multiplicity of methods and try to integrate those things and work in teams, be more interdisciplinary, as Daniel was saying, methodologically too.
So I feel like our audience is now getting going. So there's questions flying in. So I'm going to do my best to see how many we can incorporate. There's one specifically, Daniel, for you, which is asking whether you might talk about the use of transportability for implementation science. What would make transportability as a concept most useful? And any general thoughts on how to effectively apply transportability in IS? Any thoughts on that one?
Well, so to take a quick step backwards, the term transportability within epidemiology right now is being used more or less interchangeably with generalizability. It's basically about the idea that you did your study, for example, you did a randomized trial in a population and a study sample, and you want to know how those results apply in some other study sample. And there are, some other population, a target population in particular. So you do a study in Chapel Hill, North Carolina, and you want to know how that might apply to the whole state of North Carolina or to the state of South Carolina. And there's a whole body of research that is emerging, sort of methodological research that's emerging on these issues. And it is, I think, incredibly critical to this discussion. Though, again, I do think that this is where I would tease apart implementation science from epidemiologic methods that lead up to the edge of implementation science, which, again, is what I think I do. I feel like my job is, I'm not the person, it's not my expertise to know, for example, how best to implement a particular policy change in a population. That's not what I'm trained in. That's not what I'm good at. But what I can do is try and provide the best possible evidence for the people who want to do that implementation. And in my view, the best possible evidence is not, again, not about stopping at the effects of exposures, but then moving the next couple steps along the causal impact framework path to think about not just in my population, but in their population, and not just this exposure, but a series of possible interventions. And so transportability is extremely key to that, because unless you're doing essentially a large-scale randomized pragmatic trial in the population in which you plan to intervene, you are almost always taking evidence from one population and trying to think about how it applies to another population. And in fact, if you look closely at the promises you make to the Human Subjects Review Board, you are typically promising that that's the case, in that you are typically promising that the thing you are pursuing is generalizable human knowledge, which literally means applicable beyond the population being studied, right? And we don't actually examine that text very closely, but there's this actual ethical obligation, in my view, to consider issues of generalizability and transportability in most cases. So then in terms of how do you incorporate that into a realistic study, I think, what it comes down to is that if you want to implement, if you're doing a study with the goal of implementing the results in a particular population, you need to think hard about what that target population is alongside thinking about who you're going to enroll in the study. And I think that, along with Liz Stewart and some other scientists, Liz is at Hopkins, I've done some thinking, and others have done some thinking about what study designs might look like. But just to throw one possible study design out there, you could think about, for example, doing a population-based survey of your target population side by side with enrolling people into a trial or a cohort study, so that you know the population to which you're trying to generalize your results. If you were to do that data collection up front, then the quantitative step of mapping from your trial to that target population, with inverse probability weights, for example, which is a fairly straightforward method for doing that, that becomes much, much easier because you know exactly who you're trying to map your results to. The thing that I'm more concerned with, though, is asking the right question in the first place. And I think transportability, learning the concept of transportability, points us all a little bit more towards, yes, but how will this all be used down the road in a way that I think can be very useful in maybe less easily articulated ways, but ways that are important nevertheless.
So thanks for that. And it strikes me, you mentioned the concept of pragmatic trials and how we're designing our trials. There's a question that pops up, and Anna, I wonder if you might want to weigh in on it. And do you see where do pragmatic trials, as you think about them, fit in any sort of bridging between implementation science and epi? Or how do you see pragmatic trials as part of this larger process?
I think I'm going to punt that to Daniel, because I think this is more in his wheelhouse than in mine.
Well, okay, I mean, I want to hear your thoughts too, but my quick take on that is that they do a lot of that bridging work by themselves. So again, as with implementation science, people mean different things when they say pragmatic trials, but often pragmatic trials are trials in which populations are less highly selected. They're more sort of typical of the population that you're interested in intervening on ultimately, which means that the generalizability step might be extremely easy or, sort of low stress. And they often involve much more realistic, much more scalable interventions. So not the Cadillac of smoking cessation interventions that involves, one-on-one cognitive behavioral therapy and incentives and this and that and this other thing, because that's not actually scalable to 1 million people, but some intervention really is scalable to 1 million people. And so those sorts of trials often give you much more immediate and useful, you might even say pragmatic information about taking next steps and what you might actually want to do. That's my take on it. But again, people mean different things, so people might have strongly different opinions on that.
Yeah, I mean, I agree. I think, it's interesting to reflect on, the reason why classic randomized trials are sort of often put at the top of the hierarchy is because they're so clean, right? They're so, so you have this very sharp intervention and you have this, very well-defined population, and so you get an estimate of efficacy under ideal situations, and that's why people valued them. But now we're realizing, well, no, we actually have to think about how it works more in reality, more akin to effectiveness, and so this is where the pragmatic trial comes in. But maybe that's not even enough, because perhaps you need to do more to understand, because in some ways it's not just about testing the intervention, but it's trying to understand how and why the intervention works, so that then you can predict what would happen under different circumstances, because you can't test it on everybody under every possible, condition, right? So this is where I think it's really interesting, conceptually, because in reality, some people tend to differentiate, one thing is identifying causes and another thing is figuring out what works. And to me, that is fallacious, because in reality, if you understand how a system works, you really understand how a system works, you can infer what you should do to act on the system to cause an effect. So it's kind of, and this is where the connection between epidemiology and implementation science is just beautiful, because it's kind of this continuum that I was alluding to earlier. So yeah, pragmatic trials are a step in the right direction, but it might not be enough to understand all the variety of conditions under which, that can modify the impact of an action.
Yeah, that makes a lot of sense. There's a couple of questions, and here you'll see another prompt to add additional questions to the mix, and a lovely fire in front of us, very warm, at least in my screen. I wonder if we could probe a little bit, and Anna, if you want to talk about any reflections to start, and then Daniel can jump in. People are wanting to know more and more, more about this notion of the development of interventions for a sort of a local purpose versus more generalizable, and then the potential for our evidence base to create or perpetuate inequalities in communities of color. So I wonder if you have any thoughts about how do we manage the idea that we're trying to come up with interventions that are as beneficial as possible, and we need to do that in a way that takes account of those social determinants of health, that takes account of the needs of different communities and balances out that sort of local versus that more generalizable picture. I wonder, any thoughts on that kind of cluster of questions that people are asking?
Yeah, I mean, I think the issue of, what we're talking about in implementation science and how to do it and how to do it better is highly relevant to the issue of health inequities in several ways, I think. And I'll just say, a few thoughts on that. I think, as I was saying earlier, if we ignore the context, basically, and we rely on the randomized trial model, what happens a lot of times is that when we implement these things in the real world, they not only do they not reduce inequities, they increase inequities, because a lot of times those who can benefit from those who take advantage of the intervention, or even in whom the intervention works better because something about their context is interacting with the intervention to make it work, are often higher income or white populations, who are often the ones in whom things were tested in these very selected trials as well. So I think the idea of, doing implementation science or thinking more broadly about what interventions work and under what conditions they work is really important to reducing inequities. I think, because it really forces us to take into account these other factors, these that are interacting, which are often other factors in people's lives that have to do with their context, with their other experiences, it affect whether they can adopt, the intervention and whether it works in them or not. So I think it's very, very important. I think there's not enough attention. That's my impression, and I'm sure there are many people working on this, but my impression is that perhaps there has not been as much attention as there could be to this intersection of health inequities and implementation science, and how we can leverage implementation science to reduce health inequities.
So I think those are excellent points. I would just add to that that I think one particular place, so one of the ways that I think about the evidence that I want to provide for implementation science, one of the ways I think about it is that I want to provide the best possible inputs to the cost effectiveness models that will decide what it is that we're going to do. Mm-hmm. And again, it's more useful to provide an estimate of the effect of a smoking cessation intervention than it is to just provide the effect of smoking to such a cost effectiveness model, because the model cares about that intervention. But this then points towards those cost effectiveness models as, I think, a somewhat overlooked place for addressing health disparities, which is that I don't, and sort of as with what Anna just said, I may be overlooking a bunch of work in this field, in which case I sincerely apologize to the people who are working on this. But my impression is that most cost effectiveness modeling does not explicitly account for health justice issues. Mm-hmm. That most of that work is trying to optimize independent of issues of health disparities, trying to optimize independent of health justice broadly. And as with all issues of privilege, to ignore is to take a side, right? To ignore is to support the status quo. And so it seems to me that the one key point of intervention on the implementation science pipeline for better address of health disparities is to ensure that every cost effectiveness model is also a sort of health justice effectiveness model at the same time. That may be a sort of, overly positivist way of addressing this set of questions, but I do come at this from such a quantitative standpoint that that's at least where I first think. I also just, so long as I have the floor and I'm talking about this issue, I just want to raise the point that that in terms of health disparities and health justice, I think that there is a structural problem within epidemiology in that social epidemiology is considered a distinct specialization within epidemiology rather than every epidemiologist's responsibility. Because to the way that epidemiology is often structured with social epidemiology as a unique discipline, you can think about social factors, or you can think about cancer, or you can think about infectious diseases. That structuring, which is implicit in a lot of the ways departments organize, in a lot of the ways that journals organize, that is itself, I think, a kind of evidence of structural disparities that we need to think through really carefully. Because racial health disparities underlie everything we do. They are critical to cancer, just as they are critical to heart disease, just as they are critical to infectious diseases, just as they are critical to everything. And sex and gender disparities too, and social class and income disparity, all of these things, these aren't a specialization, these are a substrate on which all of our epidemiology ought to be built. And that organization is a sort of an unconscious structural bias that runs through a lot of epidemiology, and that I think we need to think about solving in a more fundamental way, that's sort of independent of the implementation science question. I don't know if, Anna, I see you nodding, so I'm hoping that you mostly agree with that take.
Yeah, I agree. I wanted to also build on an earlier point that you made, going back to the issue of, health inequities. I'm on the CDC's Community Preventive Services Task Force, which is a terrific initiative that makes recommendations about interventions and what works and what doesn't. And one thing that is incredibly difficult is that there's often, we evaluate different kinds of interventions, and often we would like to make statements, and in fact, the task force has talked about making this more of a standard, make statements about whether a particular intervention could contribute to reducing health inequities, for example. But often we don't have data to do that. So thinking about ways that the implementation science community can fill in those gaps is really important. And I think, I don't know, my impression is that it's not only or just about, testing the intervention in every single group, because we can't do that. I think it's more about understanding, again, going back to some of the earlier points, understanding how the intervention works and how other factors may modify its effect so that we can make, reasonable predictions about whether it's going to reduce disparities or not. And I think here is where the modeling, systems modeling can really help. I mean, it's hard, but I think thinking about how we can combine, evidence from a randomized trial, from a pragmatic trial, from an observational study, and from a systems model to try to make some inferences about, yes, this intervention, based on what we know, is likely to reduce inequities, or this one will actually magnify inequities, and make that part of the evaluation process of how we make decisions about what to invest in, as Daniel was saying. So it's not just cost effectiveness, but it's also the impact on inequities. That's an enormous area, I think, that really is calling out for some smart young people, dedicated people to, go for it. I'm sure many of them are on this call. So.
No, thanks so much for all of these wonderful points. And I'm just seeing another thread of questions, which is really, as you look at the hopeful intersections that we're seeing and we're trying to build, what's each of your take on impact on training? How do we train? Do we train differently? Is it about, are there certain areas in which we need to expand, whether it's in epidemiology programs or it's in, concentrations on implementation science? Are there areas that you think, wouldn't it be great if we had more exposure, whether it's on the method side or the sort of context, concepts? Any thoughts about training needs that we should, as a broader community, try and fill?
I have strong thoughts. May I take this first, Anna?
Yes.
So first, I think that training people from an explicitly causal inference point of view is very useful in helping them think through interventions and policies, because of the sort of deep connection between those things. And the language, I find that the language of sort of formal causal inference methods can be really helpful in getting people to clearly articulate what questions they're trying to ask, which I think is really at the root of maybe is the most important thing in this whole sort of implementation science and epidemiologic cascade is, did you ask the right question? Are you asking the question you want to ask in the first place? But I also think that there are 100 areas that we are not training people sufficiently in, and fixing that is really deeply fixing that, I think, is a generational process. And in particular, what I mean is that I want everyone to imagine going to graduate school in chemistry, having literally never taken a chemistry class before in your life. That's absurd, and yet that is what we do with epidemiology, oftentimes, which is mostly more complicated than chemistry. What we need is a nationwide push to restructure epidemiology education to push almost all of our grad school courses into undergraduate, so that people, when they arrive to grad school, know everything we are currently teaching them, and then we can start teaching them. And if we were able, and then again, like even if you agree with me, this is a 50-year-long process, but it never ceases to amaze me that a field as complicated, as incredibly complex and rich as epidemiology is something that we train people in. People only get 4 courses in it. Undergraduate math majors get 12 or 15 courses in math before you get a bachelor's in math. And we give people a master's or a PhD in epidemiology with 4, maybe 6 courses in epidemiology. And there's just a structural issue there that I don't, I could probably list 8 courses off the top of my head that I think we should also have, that every epidemiologist should also have, in addition to the sort of common core of coursework at PhD programs like the one Anna oversees or in my own at UNC. But none of that is really possible because everyone comes in not knowing epidemiology, and you can't ask people to take 12 courses. Like, it's just sort of not practical in our current system.
So you're offering us some real low-hanging fruit.
I'm telling you what the rest of my career is going to look like, at least on this front.
Gotcha. Excellent. Anna, your thoughts on the training side?
Well, I think, I think still epidemiology is, for the most part, I would probably still argue in most places, is still, despite the fact that we have moved away from it to some extent, pretty much focused on sort of the individual level intervention paradigm. And so I think that's a limitation. And so I think figuring out ways that our training can really expand the ability of the trainees to be thinking about interventions much more broadly defined, including broader policy interventions. And also, what are the appropriate rigorous methods to build evidence on the effectiveness of those kinds of interventions, which necessarily is beyond the randomized trial, right? The randomized trial can be useful, but you often need other things. And so this idea of multi-methods, because I think the danger, I agree with Daniel that the focus on crisp causal inference and well-defined interventions is very important. What could be an unintended, adverse effect of that is that it goes very much down the individual level kind of route and closes a little bit people's minds as to, well, yeah, there are all of these other interventions that are in the policy realm, some of which we have never done, and, some of which we have never done, and so may not be, quote, practicable, now, but might be feasible. So I think broadening people's thinking and giving them the tools so that they can provide evidence about those kinds of interventions. So, that would be my hope for, moving epidemiology training in the direction of providing, the kind of evidence that we need to make the decisions that we should be making as a society.
Great. So thanks so much for that. We only, I see, have a couple minutes left. So wonderful questions. Thanks so much also for those of you in whether it's chat or Q&A who have reinforced endorsement of different points or fleshed out the conversation. We'll be pulling all of that together. The last question that I just wanted to ask each of you, and of course, unfortunately, we only have a couple minutes for this, is just what's next, or what do you see as a key next step if the goal is, as people have been saying, trying to integrate, not isolate in our different fields? Do you have any recommendations for us all as we're listening? What would you like to see happen next to help us braid better? Anna, do you want to start, and Daniel follow?
Well, I think the idea of, training opportunities and maybe building teams, real teams through initiatives, some kinds of initiatives, centers of excellence or whatever we call it, that really attempt to bring these two fields together and focus on these big questions. Policy, in my mind, policy impacts, contribution to inequities, multi-method approaches, integrating evidence from different sources to make the best predictions possible. That would be the top of my list.
Awesome. Daniel?
I endorse all of that. I would like to associate myself with the remarks of my distinguished colleague from Philadelphia. And then I think that there are ways that we can really integrate that into training. I think, we can push our graduate students to assemble dissertation aims that point more towards policy impact, that ask those questions as well. We can discuss, health justice more explicitly when people are putting together their dissertation topics. We can, also if we're sitting on study sections, we can start to push back on grants that come in that don't mention these topics or that don't include any indication of how the science might translate into mass policy, if that's an appropriate thing to do for the grants we're reviewing. I think there are a lot of angles where we could be pushing this. I don't know what the absolute key next step is, but I do think that again, I'll just end on the same point that I started with, which is that I think that asking the right question in the first place is the key to everything in this science and really in all science. And so the more we can talk about this topic with the people at our universities and with each other, the more we're all encouraged to ask better questions that are more policy relevant, that address issues of health justice more centrally in ways that I think lead us down the path to better studies and better results and more impactful science.
Well, thank you both for that. I'm finishing where I began, which is to thank you for joining us. And thanks to everybody again for the wonderful questions, for the comments, for everything that you do to flesh out what is clearly not a one-time discussion, but will be discussions that we need to continue to have for a while. So we'll look at all the questions for what more that we want to discuss. But for now, just want to say thank you, Anna, thank you, Daniel, and turning things over to Sarah to close us out.
Well, I'm going to echo David's thanks and thank him for his moderation this afternoon. As a quick reminder, an archive of today's session will be available online in about 2 weeks. Thank you for joining us. We hope to see you at our next Implementation Science webinar. You may disconnect at this time. Thanks everyone. Have a good afternoon.
Bye.